Good morning, everyone. Welcome to cold and a bright New York here at Mount Sinai for the Endovascular Monthly Live Case webcast. As usual, Dr. Krishnan and his team are bringing forward a very interesting case. I think today he's demonstrating a new tool which has been added to the endovascular bag, which has introduced into the market. Before any delay, we'll go forward to Dr. Krishnan and his team, but I just want to remind you the next monthly live case webcast is on November 22nd. The prior webcasts are being archived in our peripheраlinterventions.org website. Please do visit and send us an email if you have any questions. Before further ado, let's go to the cath lab. Dr. Krishnan, good morning.
Good morning, Karthik. How are you?
Pretty good.
It's good to see you this morning, and I know you're a little under the weather, so thank you so much for soldiering in on this day. But we've got a very exciting day and a lot of good things to show our audience, who I know has been incredibly supportive of our program. But I want to first introduce our team, yours and mine, and Vishal's. Ray Lascano, our interventional nurse practitioner, Sandeep Singla, our endovascular fellow for 2017-18. And of course, our crack cath lab team, Elizabeth Holton, our lead RN, Marichu, who's probably on the bus on the way in, and we've got Damien today helping us. We've got a few shop things to talk to you all about. First and foremost is that this past year we partnered with the Link conference, and Dirk Scheinert, our good friend, and our other good friend, Dr. Andre Schmidt and Giancarlo Biamonino. So this year we're continuing that partnership. It's going to be Link Mount Sinai in June. I believe it's June 13th and 14th with the Fellows course on the 12th. And I can tell you that be on the lookout for all the pamphlets and all the information that's come out. We've already sent out the save the date. We will continue our combination of cardio and vascular, and having a real, how can you say, a interdisciplinary faculty. Dr. Jim McKinsey, Dr. Peter Ferries will be, and Dr. Torcello from Germany will be leading the vascular surgical side, and we will combine both the aortic as well as the difficult cases in endovascular, so everybody can really benefit from this. So we're really excited about this ongoing partnership. And also watch for further Mount Sinai live cases. We'll be doing live cases this year at Link in Germany. We've just been invited by Dr. Scheinert and his team, and hopefully also in Link Asia Pacific as well. If you happen to be out there, we will be sending out those cases there as well. So I would like to really take this opportunity to address a very difficult problem that we've all been having, which is calcification in SFA. So before we get to this great case, and I think this very exciting addition to our toolbox, I'm going to ask Dr. Singla to go ahead and start with the case presentation.
Good morning. So today we have a 67-year-old lady with a history of hypertension, type 2 diabetes, and dyslipidemia. She presented to us with the severe claudication, and which is more in left leg as compared to right. Complains of about a block claudication on the left side. Her vitals are stable. She has 1+ bilateral DPs and PT palpable. Next. Her labs were pretty normal, creatinine of 0.79. Her ABIs were significantly reduced. Right side was 0.77, and on the left it was 0.68. Next. So the strategy we had in this case was...
Oh, let's hold on there. So let's take it from there. So this is a patient who basically has lifestyle limiting claudication, had an outside intervention for a lesion some time ago, which seems to be patent on our diagnostic angiogram. So she, as the workup here in New York, it's different from other parts of the country. We generally have a lot of referrals for abnormal ABIs. And what we generally do in these patients, because they're coming from all over the 5 boroughs, is that generally we do not do the ultrasound here at this stage, because we go ahead and allow that to be done in their own communities. So this way their physician's going to have their vascular labs and so on and so forth. So this lady, we were lucky enough to get her old CD, and we noticed that she had a very calcified lesion. So before we get to the strategy, I think I want to just spend some time, Dr. Guja, with you and talk a little bit about calcification in the SFA. And I know you're ill, but I'm just curious, what do you think some of the challenges are presented to us as endovascular interventionalists with calcium?
Because I think even with DCB, right, we've been having problem with calcification. I think more than CTOs, calcified SFAs have posed a more bigger problem. That's where we have had problems with DCB and stenting also. I think Supera has made a way, Zillow PTX has made a way. I think DCBs have changed a little bit in the calcified side, but I think because severe, especially when it comes to moderate to severe calcification, even DCB has not shown a significant change in the thing because of the, I think it's because of the opposition of the drug, or probably because of the calcification itself.
Right. I think that's a good point. But if you break it down into calcification, I think there are multiple problems in the endovascular space with calcium. I think the first problem is there's no universally accepted definition of calcium.
Right.
I think if you break down the literature, and if you break down some of the controversies, like you just mentioned, the DCB, if you remember the Stellarex balloon trial that we were, the Illuminate trial that we were fortunate enough to lead here at Sinai, you can remember that our definition of calcium in Stellarex was much different than that was used by Medtronic. So
That's
you
right.
have both the calcification definitions differ depending on which one that you use. So that's the one problem. So once you have that one problem, the second problem becomes the technical issue of calcium. Well, first is, where's the location of the calcium? In my opinion, angiographic locations of calcium are very, very difficult. Is it intraluminal, or is it adventitial, or is it just where is this calcium? Because I think your therapies are dependent on where the calcium is. Third is what is it called? Is what is the best way to treat calcium? So if you take calcium and you say to yourself, if you answer the question, what is the best way to treat calcium? I think you need to understand, how does calcium impact the mechanism of failure of our therapy? And I think the jury is out on that as well. So if you look at drug-coated balloon data, Finelli with his elegant paper has really shown that that there may be, I think he's definitely shown, and I think it's universally accepted, that there is late lumen loss because of this recoil issue with calcium. But I think he's postulated that maybe calcium may be a barrier to absorption. But if you look at, and it's interesting because we know that all the companies are now, after the Illuminate data, redefining calcium and looking at calcium in multiple different definitions, and are trying to show that their DCBs do work on some amount of calcium. So the answer is, is this the mechanism of failure of calcium a recoil issue and thereby a compression, or is it a proliferative issue where you need a drug and thereby calcium acts as a barrier for absorption? So you can see, as an interventionalist, beyond the technical challenges of crossing a calcified lesion, dilating a calcified lesion, you really don't know what the right thing to do to treat calcium is. Right. And I think it's interesting because if you look at Supera, and if you believe the Supera data, I mean, it's good data as far as you and I are concerned, but it's not randomized. It's not how can you say randomized clinical data to tell you, especially the data from Germany, which everybody talks about in the heavily calcified lesions, is that you don't know whether it's the scaffolding effect of the Supera that's making a difference, or is it that calcium does not need drug? And I think the answer is we don't know. And I think that's where we need further studies. First of all, a consensus in understanding what is the universal definition of calcium that we're going to use. And this has to be done, I think, in a multidisciplinary manner using vascular surgery, IR, and interventional cardiology to come up with that definition. Right. And then second, we need to start looking at the mechanism of failures that we've had with calcium. So this topic, when it came up and when we saw the angiogram of this patient and felt that this would be a real good case to talk about, is because this is really a controversial subject. I mean, it's not simply putting a balloon in and opening it. Okay, so there's a lot of stuff to do. So let me go over the angiogram before we go over what's happening. Okay, so I will show you the angiogram.
She needs some help. She's moving.
Okay, here we go. So this is our access site. That's not important. The iliac shot here shows very, very clearly that we have a very tortuous iliacs that you would expect in an elderly person. And now I want to show you the level of calcification, okay? So when you look at this plain cine angiogram of calcium, you can see that the proximal stent that she has been there for a long time, and it's been patent. And then now you can see that she has calcium on both sides of the wall, greater than 5 centimeters on any contiguous bilateral segment. By any definition in the endovascular space, this would be considered severe calcium.
Severe calcification.
So there's different degrees of calcium, and this is one of the more severe calcified cases that anybody may encounter. The one thing that you and I think would both agree is that while a calcified CTO is a different animal, and luckily this one is not a calcified CTO, so you can see here the proximally, the lumen looks pretty damn good. Right?
Yeah.
So if you take a luminogram and you say, okay, hey, is this calcium that's in the vessel, or is this calcium that's outside the vessel? In this picture, at least, again, a very, very
looks like
poor
it's
picture,
in the vessel.
you say, well, it's probably outside the vessel, and maybe some of it is inside the vessel, right? So then if you go down below, and you take a look at the area where we're concerned with, you can see here, you again have
the
a very,
P1
very
segment.
severe compressive calcium. It seems to be eccentric. Okay, at least on a poor man's angiogram, a 2D image of a 3D object, and you can see here that it seems to be external, right?
Right.
And I want to show you the interesting thing here. If you look at the runoff here, it's focused really to the adductor canal, at least the severe calcification that we see, as a pretty good, robust distal pop with very good, I think, 2-vessel runoff. Dr. Singla was telling me. Now, in this situation, I want you guys to understand the limitations of the angiogram. Now, let's play the IVUS, please. So we did an intravascular ultrasound for all of you to understand this further.
Okay.
That's
makes
Damien.
sense.
That's Damien measuring, doing the measurement. So this is distal to proximal. So this is at the level of the popliteal, and we're going to pull back. And you can see here you have a pretty good lumen, and right there, you see, it's all external compressive calcium. Look at the lack of plaque within that vessel. So, there's a little plaque there, a little plaque there, a little plaque there. Okay, there's the plaque. Now look at that, right?
Yeah.
Okay, now look. Now there's, again, very little plaque. Look at that, compression, right? And look at that, compression. So to me, I mean, being a guy who's done thousands and thousands of these cases like you, I mean, I can tell you that this particular thing has been, I've witnessed this throughout my career, where we don't know, because we don't know what's the mechanism of this particular type of atherosclerosis and causing the stenosis. So
Right.
if I was to look at this, being somebody who's not a scientist and in the lab looking at these microscopes every single day, being somebody who's a proceduralist, what I would say is that this is not something where I need drug. I
Right.
need something here that's going to prop this vessel open, that is going to get me the maximal lumen, and possibly a scaffold is what I think I'm going to need.
Right.
The other alternative is, the moment I prop this vessel open and need a scaffold, I'm going to initiate the atherosclerotic process. And the answer is, we don't know. So,
Right.
so the challenges of treating calcium is, you have to, in my opinion, you have to break it down into, first, what is your acute goal? Your acute goal has to be to create the greatest lumen that you can. Your secondary goal has to be long-term patency, okay? But the problem is, if you look at our tools today, we don't have the tools to have acute goals, okay, in this particular type of lesion. In my experience, most of the calcified lesions I deal with are these types of lesions where you have compression of the vessel, not so much internal popcorn calcium. So if I have internal popcorn calcium, I have multiple options to treat. I can do rotational atherectomy, I can do directional atherectomy. But when I have this external calcium, the only therapy that I have is a balloon. And I know with the balloon, I am not going to be able to actually affect this calcium enough to crack it and open it and keep it open. So we've been searching for a long time on how do we deal with this. Now, for instance, with the Supera, if you don't open the vessel, and the guys in Germany are dear friends, they actually go well above the reference vessel diameter to actually sometimes even almost rupture the vessel so they can place the Supera properly, right? Because one-to-one placement of the Supera has been shown to be give you the greatest patency. But in this case, if short of doing that, you don't have an effective option. So that's why when the folks at Shockwave and our good friend Todd Burton came up with this wonderful idea, I think this really, really shows very, very clearly that this particular device may have this role in at least this acute expansion of this lesion, getting that acute result. The secondary goal, which I think was another phenomenal thought of Finelli's, is that whether calcium will act as a barrier. And the current trial that's being run by the company is actually putting the device followed by a DCB versus standard therapy followed by a DCB, which I think will answer the question that I'm looking for, which is, well, hell, is there a need for an antiproliferative agent here or not? Because if you think that there is no need for an antiproliferative agent, then the patient who gets the DCB should recoil, okay, and should restenose. So this is kind of my little breakdown on the challenges. I'm just curious on what your thoughts are before we get started.
So I think that's I think IVUS here adds a lot of benefit, right, PK? So now you clearly know it's not infraluminal or intimal calcification. It's adventitial. So you know that atherectomy has no role here.
Exactly.
So the role here is, again, I don't even think DCB has a role here, because there is not much intimal atherosclerotic disease other than the P1 segment, I think,
Right.
where you showed. So I think here all you can do is give a scaffold or break the calcium.
A video of
As you said, what we used to do previously was
I have rest.
go high pressure with a high pressure balloon and then put a supera, because supera has the most radial strength. I think that gave the most patency, but I think now that we have this new technology, it might change our options a little bit. But I don't know what your thought process is in this new technology of just breaking the calcification, or what they call as calcium fractures.
Well, you know what happens is it actually breaks it like an eggshell, right? Now you've taken a hard-boiled egg and you've hit it against the counter, and you see how it cracks, but it doesn't flake off, it doesn't embolize.
Right.
So I think this is a very, very exciting technology where it actually structurally, would that be a right word, guys? Structurally changes the calcium without actually dissecting it, right? Which is exactly it. So it actually structurally weakens the calcium by using the lithotripsy waves, okay? As everyone knows, lithotripsy has been studied, my God, extensively in medicine. We obviously use it, in all sorts of therapy, neurologic as well, urologic medicine, as well as in radiology. So therefore, this is not something new. The new part of it is that this technology has been placed on a small catheter that we can actually introduce, and you're going to see this in action very, very soon. Do we have an animation of this, or? Okay, we're going to try to pull up the animation. So now I'm just going to go ahead and tell you what we're going to do. Do we need to dilate this, guys, for this balloon? I don't think so. I mean, do you? Okay, great.
Yeah.
So I just want to, follow what they say, because to me, I think this balloon will track very, very easily across this lesion. I think it's and again, I want to show you the balloon. Can you hold this right? I want to show you the balloon. It looks, I should say the device, because it is a therapeutic device. Not that it's not just any regular balloon. You can see here that this particular balloon device looks like a regular balloon. It has these sort of dots on it, which I'm assuming are the areas in which the lithotripsy will be discharged in those particular areas. The nice thing about this is that you inflate. It is mounted on a balloon, so you go ahead and inflate this up to 4 atmospheres. And when the device discharges, you will see that you will get this sort of angiographically expansion of the balloon itself without you increasing the pressure on the balloon. And actually, the pressure on the balloon will drop, which is kind of interesting to watch. And I'll show you on the device, on the inflation device. So the interesting thing here is you're technically, even though 4 atmospheres of pressure is still 4 atmospheres of pressure, reducing barotrauma. As compared to going up, you say, with a 7mm balloon in a 5mm vessel up to, say, 10 or 15 atmospheres. I think it's a little bit different. Again, I think that their initial, you have their initial data?
Yeah.
Their initial data is very exciting, which we're going to go over in a second. So actually, let's stop here. Let's go over the initial data, and then we're going to go ahead and insert the balloon into the body. Go ahead.
Okay.
Go ahead. Can you go back to the slides?
So we can skip this. Let's go next. Next slide. So as Dr. Krishnan and Dr. Praja discussed, calcium is a challenge, both from the doability of the standpoint and even from the durability standpoint.
Almost.
And estimates suggest that there are epidemiological studies that 30 to 60% of patients with arterial disease have calcification in their vessels. Next. And again, as already we discussed, there are two types. One is intimal calcification, which is associated with within the plaque, and then the second is the medial. Now, the intimal is the one which is lumen deforming and eccentric in nature, what we have is in this case. But the medial calcification, even if it is not lumen obstruction, it can lead to changes in the vessel wall. And there is data to suggest it may impair drug permeation when used in conjunction with the drug-coated balloons. Next. 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 So, we already discussed that calcium-related complications. We definitely, people who do it, we see dissections, embolization, perforations can happen, especially in calcified vessels, and especially from the standpoint of durability, vessel recoil, which can lead to target lesion failure, stent fracture, and stent malapposition. Next. So there is data from trials which shows that calcified lesions tend to do worse as compared to non-calcified lesions. This is data from the resilient PTA arm. The overall stent rate was 40%, but when they looked at the calcified lesions, that there was a 20% increase in stent usage. Next. And this is the data Dr. Krishnan already mentioned from Professor Fennelly's paper, that as the extent of calcium increases, there is a decrease in primary patency, and there is an increase in late lumen loss, which is pretty significant. Next. Stents and calcium, we already kind of discussed that in Supera data is there, but again, it's non-randomized data. They have a data up to 3 years, which shows good outcomes, good patency. Next. But when you look at the data, it is heavily dependent upon the deployment. And if the deployment is not nominal, there is up to a 30% drop in patency with the Supera. Next. And this point, Dr. Krishnan already highlighted that the biggest challenge with dealing with calcium in peripheral arterial disease is that we do not have a consistent definition. So comparing one study to another is like comparing apple to oranges, and that becomes a challenge. And then another big challenge is that most of the contemporary studies tend to exclude severe calcium. So, to highlight the device we're going to use today, the biggest advantage I would say is that they included essentially moderate to severe calcium patients, and that was essentially almost 100% of patients had that extent of calcium. Next. Next slide, please. And when we look at the definition of moderate to severe calcium used in this DISRUPT study and compare it to the definitions from other studies, there was at least the extent of severe calcium was at least 60%, almost up to 100% when compared with other definitions. So that is, I would say, a plus point when looking at the data from this study. Next. Next. So, this is a kind of a busy cartoon, but essentially 6 steps, as Dr. Krishnan already alluded. The first step is if going from left to right in a clockwise way. So the first one is we place the balloon, which is inflated to 4 atmospheres. The second step is activating the balloon, and there is a pulse which is emitted, 1 pulse per second, and the pulse itself is lasting 1 microsecond. And then what happens is this creates a sphere of pulse, which affects the calcium, and it's kind of specific. It does not do anything to the soft tissue. And to give an idea, the pressures we deal with, the sonic pressure wave is about 50 atmospheres. And in comparison, when they do renal lithotripsy, the pressures are in the range of 650 to 700 atmospheres. This pressure wave breaks calcium. Again, as we mentioned, like of an eggshell, this calcium does not embolize, stays within the vessel wall, and gives a lumen gain. And then we increase the pressure to 6 atmosphere. Next, I'll see if the video works.
We have a video. We have a video here.
Okay. Okay. Let's play that. Okay. Yes. So we have a 014 wire. You can use any 014 wire, whichever you prefer. 4 atmospheres. Then you have there are essentially 5 transmitters. 2 on the leading edge, 1 in the middle, and 2 in the back end. and they fire in a sequence. And by trial design, up to 180 pulses per lesion are allowed, and this is a 60 millimeter long balloon. And then once we have had adequate lumen gain, the balloon is removed. That's pretty much it. Then from there on we can see.
Yep. So you can see that, listen, I mean, trials are trials, but this is the real deal. So let's see what it does here. The bottom line is, we don't have an effective therapy for this particular type of lesion.
So PK,
and we're going to go through. Yes,
PK,
sir.
we have one question here.
Yep.
The question is, how do you choose the size of the balloon?
Excellent. So you have to have. Go ahead, Sandeep.
So what you do is, this is kind of a little counterintuitive what we do in our regular angioplasty. With this balloon, you want to have a good apposition with the vessel wall to give an effective shock to the vessel wall. So you want to oversize by about 0.5 millimeter from what you think is the reference lumen of the vessel. When we angiographically did, by eyeball, we had a vessel lumen of about 5 millimeters. So we're going to be using a 5.5 balloon inflated up to 4 atmosphere to give the shock therapy. So that is a crucial step. You do not want to undersize this balloon because the effectiveness of this therapy, there is a significant decline in it.
Okay.
So you can see here that, I'm going to pull back just slightly here just to show you. I want to come across the lesion. So it comes in what, 5.5 and what, 6.5, guys?
Half sizes.
Half sizes, right? 5.0, 5.5, 6.5, is that it?
Yeah.
So you can go ahead, but the important thing, like with anything, go ahead, get everything ready, is that we have to go ahead and size it properly so that the actual therapy is delivered to the calcium. Because I'm assuming if you don't have good apposition, you're not going to have obviously good therapy, right? Would that be a normal
So
assumption?
PK, it comes in only 60 millimeter balloons?
Yes.
Yeah.
Right.
Well, at this stage, that's going to change.
And it can be
obviously.
used multiple number of times or only single use?
Well, he told you the number of pulses, which is
180 is
180 pulses are allowed. Okay. Now wait. Now let's talk everybody through this. So what we're doing now is we're going to inflate to 4 atmospheres. I like my position. If you want, I'm going to give a little dye for everybody can just cover it so nobody gets splashed. Give a little dye just so everybody can see that we're across this lesion, unless we're probably obstructing the lesion. But there's okay, we can probably come back slightly, huh? I would come back just slightly.
Just a
to
little bit,
15.
until 15.
Yeah, just come back to 15 with the dot. A little more, a little more, a little more, a little more.
That's good.
That's good right there. I like that, right? Excellent. Well, we might have to go more therapy, approximately we will. Okay, guys, now we're going to go up to 4. Now, generally, they shouldn't feel any pain with this. I mean, we've done one case where there was some discomfort, right? So that's 4 right there, guys?
no, we are not.
Okay, that's 4 right there?
That's 4 right there.
Okay, now we're going to go ahead and deliver. Ready? Go ahead. Now, see Flora, please, as we deliver. So watch. So you're going to hear a series of pops. Are you guys seeing it now? See how it's expanding?
Yep.
Go up a little bit, guys, as he's going up.
So it's connected to a console,
Yep.
right?
Now, it's not very exciting theater to watch, but I'm very excited as to what I'm able to see here right now, right? You can see it's starting to
the
expand.
proximal balloon expansion.
Right, you're seeing it expanding. Now go forward. Okay. Now we're going to pause for 10 seconds because she's warm. So it's important for the audience at home to react and understand. Yeah, you can go up with the balloon, right? Go to 6 atmospheres now. So, it's important because remember, you want to get that apposition as the vessel expands. It's not like we're treating right now with the balloon. We're actually going ahead. Go ahead, hit it now. We're actually going ahead and opposing the balloon up. Yes? Okay, there we go. And now, as it keeps coming down, you want to keep the balloon expanded, right? Right? That's the whole idea, right? And you're at 6. Excellent. You can see how it's now so nicely expanding. Look at that. Look at that. It's a little, yeah? Beautiful. I know, honey, you're going to feel a little discomfort. She's not having discomfort as much as just this weird feeling in her legs. It's not like we're giving her a lot of sedation or anything. We're at 6 atmospheres. Beautiful. Now we're going to wait. Yep. Now you can see that expansion on how it is. Do you see it, Karthik, how beautifully it's expanded?
Yep.
I mean, I would like to pull back and deliver one more therapy, guys, if you like. Yeah, I'll need to bring it up a little bit. So I'm going to come down with the balloon here, circle it down. Yep.
I think the proximal one still needs a
yeah,
little bit of.
and I think it'll be very, very good to do it. And we're going to do an IVUS after this.
So how many pulses does it deliver in one?
How many pulses per thing?
30 pulses.
30 pulses per treatment. So we can do up to six treatments per balloon. That's good right there, Ray. Go up now. Again, go to 6. I'd go to 6 here because I would go 6 because it's going to be it's already expanded distally.
Does the pulses depend on the amount of calcification PK you would use, or just angiographically you wait for?
Okay. All right, guys. Now go ahead with the pulse.
Okay. I'm at 6.
So now we're going to treat it. Again, look at the expansion of that balloon now.
Yeah.
Now watch this. I mean, it's not exciting theater. I don't think people are going to say, "Oh my God, I want to see a Shockwave balloon every day." Go up and and show it to my kids. But the bottom line is, it's very cool in the sense that, from being somebody who's treated a lot of these lesions like you have, I can tell you that this is not how a regular balloon works.
Balloon expands.
A regular balloon will expand. Will have differential expansion. It'll actually possibly perf the other side of the vessel wall. Okay, because what will happen is it's going to expand towards the area of least resistance first. So here, look how smooth that balloon is expanded.
Yeah, especially at number 10.
Very, very complex lesion, and so that I got to tell you, this is. I mean, if this is going to be something that's going to be part of my regular everyday armamentarium, if this is the kind of results I'm getting, go ahead one more time. I'm going to give one more therapy, guys. Yep, I like this spot. Okay, honey, hang on. Is she okay, guys? Yeah, she's a wonderful person, very talkative, so that's good. So here we go again. We're giving one more. See that segment around 10?
That's
is
right.
Where I'm not as happy, so I'm just going to go up to 6. Right here. There we go. And then I'm just going to go ahead and just let it expand. There you go. Look at that. So I'm actually going to have to bring up the dot up to 10 now to treat that area.
Right.
Because I think what's happening is we're in that intermediate zone where we're not treating the calcium in that area. So I'm going to go ahead and let him finish this one cell. But that's 120 cycles I've delivered. I'm going to come down, and I'm going to pull up. And I think this is going to become what we're going to learn with this particular device is, kind of the art of using the Shockwave, where you look at the angiogram and you start saying to yourself, or they should say the fluoroscopic image. Yep, that's good right there. And you start saying to yourself, hey, I'm not delivering therapy at the site I really need it because that area is not expanding. As you can see, our pressures are very low, and now we're going to go ahead now and deliver therapy at that spot. Go ahead, hit it now, guys.
So PK, if I'm not wrong, for the Disrupt PAD, right? I think the Disrupt PAD and the Disrupt PAD2 together, they had 95 patients? Is that it?
I believe
95 patients?
It's 95.
95 patients, and they stented one patient, right?
Well, yeah, the advantage of this particular device is that your stent has use is really minimal to none, 0 to none. If you look at 90 patients, you put one stent. I mean, it's almost a very, very, very startling number that would be that low.
They said that.
And if you look at the level of calcium and you compare it to the rest of the trials on the Disrupt PAD definition of calcium, it's actually probably the heaviest calcium trial ever done.
Right.
Pull back. I want to go up. I want to go to that proximal region. See right at 10. Put the dot at 10 for me.
I think even the CTOs, PK, I think out of 95, 18 were CTOs, I think, calcified CTOs.
I don't know the exact number of calcified CTOs. Yeah. I can tell you that we did a calcified CTO just Monday with this particular, right there, with this device. I can go down a little bit, guys. Go down a little bit. I'm okay there. Go down a little bit. I'm gonna just slightly, right there. I want the dot right at 10. Right at that. Yeah. Now go up. Okay. So I can tell you that in calcified CTOs, it's not in the trial. If you're subintimal, right? I don't think you could do it. And in the study itself, it was 8% CTOs. I'm being told. Right. So I'm sorry, 18% CTOs.
Right.
So I think that they studied CTOs. It's safe. Okay. It's not going to have a deleterious effect on the CTO. Go ahead, deliver. And I think this is going to be my last therapy. This is going to take me to my 180 cycles. And then I'm going to run my IVUS, and then we're going to take a look. If we need to open another balloon to do distal.
I know Michael Jaff was talking about this in Viva 365, So he was talking about this with Krishna and I think Dr. Burkett.
Well, I think that's great to, I always believe the proof's in the pudding. And as you know, the way we'd say at Sinai, if you want to see if a device works, send it to Sinai. We'll put it to the test in the hardest lesions.
That's right.
I think this is a very tough lesion, and I think this device is performing really, really well. So, I'm very, very impressed, like I was Monday when we did our other case. And you know, if you look at the amount of pain the patient would have had with a standard balloon, Elizabeth would have been, you know, running around with pain medications trying to help our patient. But at this stage, you know, it went up really, really nicely. There was very minimal discomfort to the patient, although I'm certain that as in any sort of device, there will be some associated discomfort. But I think that, you know, this is very, very good. I'm very impressed by it, and I think that this is going to be an effective tool. I don't know, you know, like I said, there are a lot of unanswered questions with calcium, and I think we're going to answer those questions slowly, but this is going to be part of our solution to these type of very difficult lesions. IVUS, please. So now that we're done, we're going to send the IVUS down, and I'm going to go ahead and record again.
Okay.
So I think based on the trial, they had 76% success rate of expanding the lesions.
Okay.
I think they had 96% patency rates for 1 year. I think
Yeah, I mean,
No, they don't have
6
1 year.
months was reported.
6 months
if I
was
remember
reported.
right.
6 months was reported.
1
also.
year is pending. And you
Yeah.
know, listen, again, I don't think they're going around saying that, you know, this is going to improve the patency of the vessel. I don't think the company, I mean, I may be wrong and I don't want to talk for them, but, you know, I don't think that they would be saying that. What they're saying is that, you know, even in the study, they're putting it with another balloon, I mean, with the drug-coated balloon as a therapeutic agent. So I think, you know, this is an effective balloon in this type of calcium. Go ahead, on please. Let me pull back. And now you can see already the area is expanding. Look at that.
Nice.
Well, you'll see as we get closer. Okay, look at that. That was very tight, right? Look at that. Look at that. Guys, this is startling. Look at that. Little dissection, but again, you know what? That's nothing in my opinion. Look at that, how beautiful that is. Now, if we could do
That's a
OCT
great luminal
if
gain.
we do OCT in the peripheral, which we can't, obviously, because of the size of the lumen and the
Very
flow, look at how
Very nice,
nicely
very nice.
it's expanded.
Very
You
nice.
know? Look at that. A little bit of external compression, but you know what? That's still a very good lumen compared to how it was. Again, look at that, guys. So now, I'm going to go ahead and take an angiogram, what we all live by, right? Let's take our angiogram.
I think Sandeep, remind me again. I think with the trial they said the luminal gain is 3 millimeters.
Yes, 2.8 and yeah, and you know they were looking at 50% residual, but when they analyzed the data, their residual was 23%. That's why you know their parameters they changed it to for the pad 3, they have 30% as their goal now.
Okay.
Yeah, rather than 50%.
You know, it's like I said. You know, I really don't think we've found that holy grail to. Oops, she's moving. To the answer for patency and all these types of lesions. You can see there's no embolization. That's all I really want to show here. So now I want to go ahead. Now I'm going to go ahead and give therapy. Now, I'm going to contradict myself here and say, what should I do? I mean, here we are. We've got beautiful expansion with our Shockwave medical device, which is very, very impressive. So the question now is, are you a believer in scaffolding? Do you think that you need to scaffold this, or do you think you need to do anti-proliferative medication here?
PK, why are we talking about DCB here? There's not much intimal I mean, there's not much intimal thickness, right?
Well, listen, I'm being if you look at their study is comparing it to DCB. So obviously there is a school of thought out there that says that this could be proliferative disease that's going to cause the mechanism of failure. And I think that honestly is a lot of the problems. And you know, and with our discussion here and why this program has really taken off is that we talk about these controversial thoughts that you know that are not necessarily addressed in the meetings. So you know, if you look at this, you know, you have to now choose sides. You
Right.
have to say, hey, the mechanism of failure here now is going to be recoil and then restenosis, or the mechanism of failure is going to be a drug-coated proliferation or proliferation that's going to occur because of disruption. I can tell you my thoughts by looking at the IVUS. I think my thoughts by looking at the IVUS are two. One, you have wonderful lumen, you have some non-flow limiting dissections, very, very small, and I think that's all part of any sort of therapy that you're going to have here, for sure. And definitely something that does not need a stent. And third is, you have good expansion, but you do have some amounts of recoil in the proximal area. So if you look at our angiogram, right, let's learn from our angiogram. You could see in the angiogram here, in one view, you could see here that you have a much better lumen across that segment of 10 and all that. But you can see you have some fracture of the plaque and the fracture of the calcium shown by the, the dye kind of leaking out around 10, around the plaque, right around there. You can see that. So it's almost like, you've fractured, you've done the lithotripsy job that you wanted to. So now the question is, and I wish I knew the answer to this, is what's the right therapy now? I'll give you the options, and we'll have a show of hands in the room, all right? And if the audience wants to chime in with what they want to do, because truthfully, we don't know the true answer. So one, do we do nothing, leave it with lithotripsy alone? That's one. Two, do we do plain old balloon angioplasty, a prolonged balloon, okay? And if we have a good lumen, we leave it alone. Three, do we do a supera stent? Okay. Four, do we do a Zilver stent? And the last one is, do we do a DCB? So again, and I'm not putting bare metal into the picture here, bare metal self-expanding stent, I'm not putting that, okay? So how many of you would do one? No one. Okay, so everybody agrees that lithotripsy will be probably a therapy at this stage. So this way we're now able to do another therapy which may be more of our definitive therapy, sort of a pathway to definitive therapy, for a lack of a better word, right? So second, so lithotripsy is out. Who would do standalone balloon angioplasty here? I'm looking at my old fellow Dr. Majid, who went over to the dark side, and then no one. Okay. Three, who would do a supera stent?
I would probably do a supera.
So we have one, two, we have a few people doing supera here. Three, who would do a Zilver PTX? Interesting. I thought we'd get some, but nobody wants to do a Zilver. And who would do a drug-coated balloon? One, two. You two, any opinions? Drug-coated balloon, what do you guys think? Okay.
PK, what do you think?
I'm curious of what everybody's thinking. Nobody's like, I don't understand this. I'm not going to take your money, guys. I mean, there's no right or wrong. I already told you you're going to win. I don't understand. What's that? Oh yeah, you want to? Okay, at the 10. Okay, we'll do one more. I think that makes sense. Okay, so there is a thought here that around 10 we should put the center emitter around 10, but we did that. We did that.
We did that twice.
So we did hit that.
PK, my concern is the number 10 is the recoil part. Even on the IVUS, I think that's where we had the maximum recoil.
Well, that's the area where they feel that we should go back and hit it. Listen, we have time, so let's go back and hit it. All right, give me another one. So we'll do 20% more energy with center emitter. Got it. Let's do it. Give me another catheter. We're gonna go back.
You know, PK, I feel like I'm in Star Trek. You know, every time you want a little bit less, give more energy, go into the outer space.
Yeah. Why don't we go with a little bigger balloon, guys? Yeah, let's go with the 6. We're not undecided, but let's go with the 6. I agree. Let's go with the 6. So Ivan said it was 4.7 distal, but you have to assume that the proximal luminal diameter may be a 5.5. So therefore, we're going to go with the 6 balloon here and try to get a better expansion. So let's see.
PK, you want to watch that distal wire?
I know, I saw that. Yeah. I was actually trying to pretend that I could sneak one by you there, Dr. Guja. It's not very good, Dr. Guja. I got to talk to Gopi about this. There you go.
Wire discipline. That's what I was taught.
Oh my God. So we're going to go with a 6 millimeter balloon here, upsizing. And I think, look, guys, you might say, oh, well, in my practice, I'm not going to open 2 of these balloons. And the truth of the matter is, this is a process of learning. We learn how to deploy a supera. We learn how to do directional atherectomy properly. We're learning how to do lithotripsy properly. And part of that is this kind of situation where we're learning. So let's go through the prep, Ray, while you're doing it. Go through the prep.
Basically, it comes out of the holder itself.
Oh, no, he doesn't have a microphone. You go. You talk.
No, I didn't do it. Actually.
Okay. So talk loudly, Ray.
So basically, it comes out of the device. It's the holder itself. We prep the balloon like a regular balloon that we normally prep.
Can't hear? Can you hear?
Yeah, we can hear. We
So-
can hear. We
Okay,
can
go.
hear.
And 2 pullbacks on the balloon so that there's no the negative pullback, so there's no air in the balloon itself, and we have some contrast in there. And then what they like us to do is to put it through a
Ultrasound.
ultrasound probe cover so that the device could stay sterile while we do this procedure. So what I'm doing now is we got the device probe cover. I'm inserting the device through the cover. So we kind of modified to get this through. And as we get it through, we're going to make sure that everything is covered up. And then it attaches to the actual generator itself when we're ready for it. So I'm just going to have to tape this up here when we're done. Tape it up with some Tegaderm so that it doesn't get loose.
Now this entire thing is sterile here, guys. So I don't want you to think that it's like a crosser catheter or something like that.
Correct.
This entire segment is sterile. We're just doing this as a recommendation by the device company. And now we're going to hand this to our very own Damien.
I'm going to attach it to the actual generator plug.
All right, there it goes. And now Damien's going to pull this through. All right, let me have the device, please. So now we're going to
You have
go.
to flush it centrally on one
Yeah,
side.
yeah,
Flush centrally?
it's flushed.
Okay.
They made it very sleek. That's what I should say.
Well, it is sleek. I mean, the only question, there's a lot of issues with this device that's going to come out. One is the reimbursement. I mean, I know that the company's working very hard on that, trying to get a reimbursement code for us so that we can use it. And two is obviously, once they get that, was that going to cover the cost of the procedure and the cost of, the device, using the device? I mean, I think as we've shown, in these complex lesions, this is a very, very effective device for us. So, I think that, this is, again, with any new therapy, this is the challenges we face. Look at what we're facing with drug-coated balloon technology as we speak. Let's see, is the center lumen at 10?
No, one
No,
back.
we have
One
to pull back.
One
One
back,
back.
right?
That.
Hold on, I'm coming back.
Back.
Right there.
Right there.
I kind of like that.
Yeah.
I kind of like that.
And
All right?
then 10.
Between 9 and 10, right? Well, we're going to come back a little more then, right?
So this is a 6 millimeter balloon, right, PK?
Yes,
This
we
is
went
a
for
s-
6.
Right there. Okay, there you go. That's between 9 and 10. Okay, good. So now we're going to go up with a little bigger balloon. Again, the same thing, guys. We're going to go to 4. And honestly, I think we're going to get better with the sizing as we go forward. Generally, we went with the distal reference vessel. Maybe that's not the answer here. Let's see. So he is going to 4. Okay, ready? Go
I'm
up
at
now.
4.
Pulse. Press the button. Everybody get a coffee. There we go.
Keep it pressed.
So you have to keep the button pressed, PK?
Yeah. It's coming up.
It's opening.
Yeah.
I can see it.
Pressure dropped it.
That's good, and the pressure is dropping, which is what you want. Right, and we're going to go up a little bit to keep it opposed.
PK, what do the patients feel during that?
Nothing.
Okay.
She felt hot. I'm still at 4 atmospheres.
Okay.
Okay, we're going to treat again and go to 6.
So wait 10 seconds.
We're
Okay.
going to wait 10 seconds.
Okay.
Go. Now I'm at 6. Go.
Mm-hmm.
Go.
Yeah.
So I'm thinking that maybe our reference vessel diameter, we should go 1 millimeter above the reference vessel is what I'm thinking, rather than a half. I think in my, again, I'm not an expert in this, but I think that the clinical, I understand from the company's perspective, you want to watch out for flow limiting dissection here, but I think here definitely a 1 millimeter balloon probably would have been more appropriate.
Yeah.
But I think, you're going to learn. It's like anything with the DCBs. With Latonics, you learn that 1-to-1 sizing, a little bit above 1-to-1 was better. I'm done here, guys. I'm coming down. That looks beautiful. All right, let's walk this out. Let's do another IVUS.
PK, this balloon doesn't cause any neurorevascularization or anything like that, right? It's
Well,
only just.
I think experimental models is what they have at this stage to talk about that stuff. Not that I'm aware of, but I will wait for them. I don't think they're aware either. Probably Todd would know more whether that occurs or not.
Because they talk only about disruption of calcium. They don't talk anything about neurorevascularization.
Right. Let's go, guys. Give me the IVUS. Great. IVUS coming in. Last IVUS run. So the vote was for DCB, huh?
Yep.
Interesting. So Dr. Singla, why do you want a DCB?
Two reasons. I think there is data from Professor Fanelli's lab where he showed that the impact of DCB is influenced by calcium. And I think once we break this calcium, there is, even if the initial process, the causing calcium was not related to, is not related to proliferation issues, but once we dissect the vessel and cause injury, I think the drug should inhibit the proliferation as a healing response of the vessel. So I'm hoping,
Ready? Pull back.
Okay.
Go ahead, we're listening.
So I think with the DCB therapy after this, the calcium as a barrier is gone. So I'm hoping there is a better outcome. And then second is, these people, these are not like one-time fix. So the lesser hardware we leave in there, the better it is. And Supera can be used, but it's a bulky stent. It takes away 0.5 millimeter of the vessel lumen, or 0.3 millimeter of vessel lumen. And there is good patency data, but again,
Where is this PK?
This is 10.
Yeah.
This is 10. Again, I'm telling
recall.
you. So you saw how much loss was there.
Right there. Look at that.
I mean, I don't know if DCB is going to be able to keep this open, even
Right.
with lithotripsy, if you're having so much acute luminal loss, whether you're going to do it. So I'm going to go completely opposite here and deploy a Zilver. I'm going to say to you guys, you know what? I don't believe anything you're saying.
PK, you think Silver has the radial strength? Because
I personally don't think you're going to need radial strength. I think this is where my lithotripsy's done a wonderful job. I think that I agree with the proliferation issue. I need the scaffolding issue. I know that Zilvers don't fracture at the size I'm going to put it at. It's only 1.8% after 3 years, up to 3 years, and no difference after 5 years. I think that the drug is going to be important to prevent, because there is going to be some proliferative response, possibly, and I need scaffolding. So you know what? I'm going to go with the Zilver. Probably 80.
80?
Yeah, this is a 60 balloon.
7 or 6?
I would
It's a
go with the
60
6080, right? 6080.
680 is good.
Yeah, let's take a
680.
I mean, I know that nobody in the room is happy with me, but
No, that's a reasonable choice.
I mean, I definitely want to make sure. Look at that. So the only thing you gotta, before I put my 6080, I want to have a 6040 Dorado. So now I've decided to stent. Okay. So now what I want to do is I want to completely expand that area where I'm concerned with, where we delivered the second Shockwave. I want to expand that area with a 6040 Dorado. Okay. And then I'm going to deliver my Zilver. Actually, give me a 6060 Dorado.
Even at number 14 PK.
I'm going to I'm going to do for the whole thing 14 up. That's what I changed my mind.
Yeah.
And I'm going to put an 80 Zilver. And then I'm going to see this lady in 10 years patent.
Very optimistic.
I am.
Your optimism is getting better and better every day. Looks like I'm rubbing off on you, PK.
Absolutely. Absolutely. So we're going to go with the Dorado here. And again, I want to see what atmosphere it takes for my Dorado to expand. Now, ready, guys?
PK, we never talked about covered stent here.
Well, I don't think there's any reason. Why would you worry about a covered stent here?
covered stent
Nice
here.
I'm just saying, throwing it out there, devil's advocate.
I think covered stents are great, but I don't think we need it here. I think when we need it, they are phenomenal. I think at this stage, you really don't need a covered stent. Well, this is interesting because the balloon definitely tracked easily, right? So I'm just going to pull back slightly to
I think that's pretty good.
Yeah,
there.
right.
Okay. All right, ready to go up? Let's see. Okay, let's see. I'm going to use this as my acid test for my Zilver. Go slowly.
One.
That's 1 atmosphere. Look at that expansion, guys. Look at this. 2 atmospheres. 3. Distally is an issue, but that's okay. 4, 5. 5 atmospheres. Beautiful.
6.
I kind of like this. 7. Nominal. Let's leave it up for 3 minutes. Watch paint dry. So, anybody going trick-or-treating soon? Liz? Plans? But look at that, look at that expansion card. I think I want to show you in two different sides here. Look at that. There's no compression.
You're leaving it for 3 minutes?
Yeah, I'm just going to see whether I can maybe follow direction a little better, listen to my fellow, and do a DCB. You know? You know, trying to convince myself. Because when I said over here, everybody let out a collective sigh of, oh no.
No, I think silver is reasonable. I mean, the fracture rates are not high; they're pretty low. In this area, it's calcified. You'll have drug as well as scaffold.
Well, that's the point, right? I think when Alluvia comes out, I think it's also going to help change the game, give us more choices. I think we're going to have head-to-head data with Zilver versus Alluvia for the first time to tell us, you know, whether they're equivocal or one is superior. I think, you know, it's very exciting times. I mean, for me to achieve this, I know we took longer because we're yapping away. We would have been done with this case in 20 minutes. So I think that this particular one is really a game changer for me, this particular device. All right, down. That's 2 minutes in New York, guys. Down. All right. That's called a New York 2 minutes. Walk it out. Actually, let's change out for an 035 Supercore now. Since we decided we're not using a Silpera at this stage. Okay. Okay, Mom. Hang on, Mom. We're almost done. So we had a 5 atmosphere inflation of a 6.0 balloon. We're almost done, sweetheart. Very good. Excellent. Come back up. Walk it out, Ray.
So let's see what did your balloon do?
It definitely didn't do anything except good things. DSA?
Such optimism.
All right, Liz, you can't move. Don't move, my hon.
See, PK, how would you follow this patient?
I think ultrasound follow up the way we do it. Look at that.
Looks better.
Looks much better. Let's take a picture again.
Don't move.
I mean,
I think stent is.
you wouldn't stent this now?
I would.
All right. I'm going to listen to my fellow. Give me a 6.0 DCB, 6.0 impact.
I don't know. You still think the 10 is okay? Number 10?
You know what? I think that there is a little bit of recoil there, and the issue there is going to be whether you want to spot stent versus impact the whole thing.
I think 80 is okay.
Hold on. What?
You can go with you can go with 680 stent, PK, silver.
So stick with my gut?
Yeah, I think so.
All right, give me a 680 silver.
I think that will be totally reasonable.
I want the audience at home to understand is I'm not a fickle person, okay? What I'm trying to say to you is we don't know what the right therapy here is.
I think that's...
Okay, so logically speaking, with my experience, I can tell you that there is recoil at 10. It's not a significant recoil. It's not flow limiting. But my question is, I don't know if that recoil is going to contribute to the failure of therapy here. And so therefore, I'm going to do a drug-coated stent.
PK, TASD lesions, calcified SFAs are the Achilles heel for endovascular world right now, right?
Well, remember, but we've changed this process right now with the lithotripsy balloon. See, the balloon has changed the process right here. But listen, at the end of the day, you got to stick to your gut, and I'm sticking to my gut here. I think we're going to be okay. I know that that there is going to be scaffolding necessary, I feel, just because of the nature of this lesion. And you're going to see the expansion of the silver really demonstrate how beautiful this balloon works.
You want to get it out of that tape, PK, or?
Huh?
You want to get the stent out of the tape?
Oh, you want to see it expand? Okay.
Yeah.
Well, you're going to have to balloon it. You know that.
You want to come back a little bit?
Go C minus here? I think we got plenty of room.
Yeah,
If anything, we need to go forward a little bit.
It's a little bit too dark for us, so.
No, I think if anything, you got to go forward a little bit because
Start at 15,
15
right?
is good. That's where we are, right?
We are a little up.
We got to go down a little bit.
Yeah.
If anything, we got to go forward. There you go. There you go. Now we're okay.
That's reasonable.
Show me above. Great. Walk it out. Give me that 6.0 Dorado back. Actually, guys, this is screwed up. Give me a new 6.0 Dorado.
So you said you're going to follow this by ultrasound, PK, right?
Yes, sir.
How do you do it, PK? Like every 1 month, 6 months, and 12 months, or?
Unfortunately, you know, the problem is most of the surveillance data is taken out of bypass grafts.
Right.
As you know, the bypass graft mechanism of failure is much different than the mechanism of failure of you know, stents. And also the consequences of failure are much more catastrophic in a bypass graft. So as far as I'm concerned here, I would go ahead and follow this every 3 months for the first year. And then the question is, would I intervene? I would intervene if the patient is clinically symptomatic.
Right.
If the patient is not clinically symptomatic and or I don't have a physiologic test to show me that their ABIs drop with exercise, then that may be different. You know, if it's just asymptomatic, elevated high velocities, I probably wouldn't do anything. All right, guys, let's go up here. Now we're going to crack it. Now we got the drug going. And the nice thing is this stent, this size stent, this location of stent has been studied in the Silver PTX trial.
Right.
So you can go ahead and
Also calcified lesions, right? Dr. Fenel's data has been shown.
All righty, go up. 7, 8, 9, 10. Okay. Down. Nice expansion. Very good. And then come back slightly. And go up here.
Looks like the expansion is very good.
Yeah, it's very, very, very beautiful. I got to tell you, look at that. Beautiful, symmetrical expansion. And maybe come back a little bit more proximally down. I just don't want to come outside the stent. You know, I'll go up a little bit. Our peripheral balloons are, as you know, trucks. So unfortunately, it's going to you know, affect the area outside. So I don't want to traumatize the area. Yeah, that's non-drug, doesn't have drug on it. Okay, down. Again, one more time here. Okay, down. Okay, good. All right, we're done. Walk it out, guys. DSA. Actually, let's do an IVUS. Give me an 0-1-4 wire.
So PK, if you had intraluminal calcium, intraluminal calcification, would you have done atherectomy and then do a
I think
lithotripsy balloon?
The cool thing is going to be to talk to the company about how they do with intraluminal calcium. I think they believe that everything will be worked just as fine, whether it's luminal popcorn calcium or external calcium compression, right? So they really feel that, and I'm sure they have, you know, Andrew Holden and our good friends in New Zealand have done a lot of work on this. So I think that, you know, that's a valid statement to say that it will be effective in that type of lesion as well. However, if you did not have availability to Shockwave, or if you felt that, you know, at this stage you want to do, you know, regular atherectomy, then you could do a rotational directional atherectomy in this particular lesion subset, and then do well. Walk it out, Ray. All right, now give me the IVUS. Now the beauty here is you could say, oh my God, did you burn a bridge to therapy? And the answer is no. There is no way that a surgeon is going to bypass to this particular area anyway. So putting a stent here doesn't burn a bridge to therapy. If you had gone any further down into the popliteal artery, then I would agree that you probably did burn a bridge to therapy. The other question is whether endovascular therapy is going to reduce the outcomes of surgery. I think there is some data in critical limb ischemia that shows possibly, but this is not a critical limb ischemia patient. And I think 9 out of 10 surgeons or 99 out of 100 surgeons would have done endovascular first in this case as well,
right,
before they went to surgery.
Agreed.
So I think there's a lot of interesting stuff for us here. Ray, you want to go to 4? Get started.
So how was your experience in a calcified CTO, PK?
You know, this device performed remarkably well. You know, it was very trackable. I was surprised at how trackable it was in a very, very fibrotic and calcified CTO. It expanded well. We were actually more as aggressive with the sizing as we were with this particular case. Actually, more than this case, because we went with a 6.0 initially to start with. And we were able to place, obviously in that case, we needed a stent, and we were able to place a Zilver with excellent expansion in the very, very calcified lesion that we had. So fantastic, fantastic results all the way around. So that's the proximal stent. And there's our distal stent. Ready? So we're just going to pull back. And that's the beautiful apposition of the stent. Look at that. Circular, sort of like the videos of the Supera, right? Post-Supera deployment. Look at that area right there where it was
Very
compressed. You see that? Little compression, not horrible, right? Look at that. Beautiful. Beautiful. Very, very, very good, very good. Okay. DSA?
I think that's really nice.
Yeah, I think it's very impressive. Huh? Okay, tell her not to move. Don't move your legs, sweetheart. No te mueva. Look at that, beautiful.
That's really nice.
That's really nothing. It's fantastic. Could we have put a Supera? Yes, if it had a drug, I would have done it. Excellent flow.
That's very nice.
2 vessel now, you can see 3 vessels when you couldn't see 3 before. And all the way down to the foot. Again, telling you there's no embolization with this device. And with most and by the way, guys, we did not use a filter on this device. So remember, that's okay, she's moving. Sorry, my love. So again, excellent case. We're done with the case, and I just want to give a quick recap. You know, as you saw in this case, I mean, we really talked about all the unknowns with calcified SFA lesions. We talked about the challenges, the assessment, the definitions, as well as the therapies that are available, their limitations. I think the key, if I was to tell all of you at home who are doing these kind of difficult cases, is first and foremost, you need to assess, is it luminal calcium, compressive calcium, or I should say adventitial calcium or not. I think it really changes the way you're going to approach this lesion. Because I think if you have actual luminal popcorn calcium, you have obstruction within the lumen, and you need to remove that, whether it's with a lithotripsy device or whether it's with a directional atherectomy device. You have more choices in that particular type of lesion, or a rotational atherectomy device. When you have compressive calcium on the external, you're really limited. I mean, you're limited to prolonged balloon angioplasty with a large balloon, almost essentially rupturing the vessel in order to really expand the vessel. Versus now, I think a very viable and very, very effective alternative, which is now the Shockwave Medical. I mean, as you see, the lesion we picked was not a vanilla lesion. It wasn't a quote-unquote calcium lesion. It was a severely calcified lesion with severe luminal compromise. You saw how the device works. I mean, very important. I think you need to first assess the reference vessel diameter. You saw the learning that we had. We probably undersized it by 0.5 millimeters, and we went up. We had the luxury here to go up to another device, but I think in your hands, you might want to be very, very carefully assessing both the proximal reference vessel and the distal reference vessel, understanding that the vessel may change in diameter, and then choose the vessel that's most appropriate to get a one-to-one sizing of the lithotripsy device. Number two, you also want to make sure that you prep the device properly. You saw the prep is very easy, very fast, not much education when it comes to to your staff to really go ahead and get this done quickly. Third, the capital equipment. You can see the device over there, very, very small, not a large. Can you show the device, guys? The actual device over there, very, very small, almost like a laptop size device that's on the corner there. Which they're not able to quite see, which they'll see now. They're going to pull it towards him. So anyway, they'll show that to you in a second. So again, it's not going to be very, very large for them to be able to do that. Then finally, okay, I'm going to look here. Then finally, you saw the way we deployed and actually used the lithotripsy to open the calcium. Very important to see the areas, study the lesion, go up to 4 atmospheres. When it expands as the device discharges, take the atmospheres up slightly to 6 to really oppose the balloon up against the calcium to expand the lesion. If you have up to 6 cycles, right? I believe the 6 inflations, so you can pull back slightly, to be able to put that center dot, as I was educated, up against the most resistant lesion, because you have more, how can you say, capacity to impact therapy from that center dot than the peripheral dots. So that's also important. Then, of course, we went through the old algorithm of what to do, because I can't tell you the mechanism of failure. I think a lot of people will talk about it, but the answer is we really don't know. I really felt that drug with scaffolding is important, because intravascular ultrasound made all the difference in this case. It allowed me to see that around 10, even though I did 2 separate shockwave balloons, there was a little bit of recoil that was really, really clearly handled quite well, although not completely, by the Zilver PTX stent, which allowed me to have scaffolding plus drug. And now the final thing is now surveillance. Dr. Guja went over that. We're going to survey the patient for every 3 months for the first year. Antiplatelet therapy, we're going to follow the Zilver protocol for out to 3 months, okay? And then we're going to see this patient in clinic, and hopefully she has a remarkable relief of her symptoms. Again, I thank my fellow, there's the device. So there's the Shockwave device. You don't need both of them. It's just you just need one, right, guys? Am I right? Yeah. So I don't want you guys to think you're going to get 2 devices. You're just going to get one. And you can see it's very, very small, very portable, and really kind of out of the way in the lab. Once you use it, you can put it away somewhere. It's not going to take up a lot of room. So it's not a big investment in space for your lab. So again, I want to thank Elizabeth. I want to thank Sandeep. I would like to thank Ray, who left for the next case. And most importantly, really our friends at Shockwave Medical. They've been really supportive to us in this case, and very, very helpful in educating not only our staff, but our entire community online. And you too, Dr. Guja, thank you so much for coming out. When
Excellent job, Dr. Krishnan. So guys, as you have seen, Dr. Krishnan, as every month, has demonstrated excellently the new Shockwave therapy device, which has been added, has its own role in the endovascular toolbag. So again, we look forward to seeing you again on November 22nd for the next live case webcast. This live case will be in the archives in about a week. You guys can watch it. If you have any questions, email us, and we'll be more than happy to answer all your questions. Looking forward to you again next month. Have a great day.